Hello friends, welcome back to my channel with a new video and part 2 of Weaning, which we left last time, and we were discussing about the various SPT studies comparing the SPT, the TPs versus pressure support versus CPAP versus automated tube compensation. So moving forward, as you could see, that there are a few TP studies. We looked after the SPT studies last time, and this particular TP studies, where this particular paper from Brazil in the Cochrane database systematic review in 2014, they compared SPT and pressure support and SPT with TPs, taking into account the weaning, the reintubation, and the length of stay in ICU as well as in the hospital, and they could see that there was no difference in either of the strategies. Coming to the another paper which was published in Chest, and they took into account the reintubation, and they compared SBT plus CPAP of 5 centimeters of water and SBT plus TPs. Again, there was no difference. And of course, this particular paper from the Switzerland, the Swiss group, where they had a weaning success with no reintubation within 48 hours, taking into account the SPT plus ATC, that is automated tube compensation, or SBT and TPs. Again, there was no difference. So as you could see that ATC versus CPAP, there was no difference in reintubation. ATC with versus pressure support, there was no difference in reintubation. These were the studies published in Critical Care Medicine, respectively in 2006 and 2009. So this is a particular literature which we discussed upon the TP studies, and let us go back to the bedside as to how we assess the readiness to wean. So this is the step 1, and there are few objective criteria. For an example, oxygen. So we need to have an adequate oxygenation, the PF ratio of between 150 to 200, requiring the PEEP maybe between 5 to 8, and FiO2 maybe close to 40% or 50%. You have the temperature which is normal and the patient is not febrile. With good hemodynamic stability, heart rate which is less than 140, so no tachycardia, stable BP, no vasopressors, no evidence of myocardial ischemia, with a good hemoglobin and adequate mentation. And the subjective criteria of course, the resolution of the disease, acute phase of the disease, with good cough reflex. This was a very famous paper which was published in 2015, and it talked about the objective as well as subjective criteria for the readiness of weaning. Now, what are the means or the ways of identifying the weaning success? Rather, when do we decide that the patient can be extubated? So patient should be conscious, and of course the secretions are less, with a good cough reflex, and I will be definitely worried if the patient is agitated, delirious, tachycardic, tachypneic, hypertensive or hypotensive, and with ABG abnormalities like acidosis. As you could see, either could be a metabolic acidosis or predominantly a respiratory acidosis, which will definitely give me a indication that this patient may not be ready for weaning. Along with hypoxia, if the PO2 is less than 50, then I will be definitely worried about the same. Now these are a few of the weaning indices, and talking about the minute ventilation with a threshold of about 10 to 15 liters per minute, NIF of about -20 to -30, the negative inspiratory fraction, the PI max in between -15 to -30, the respiratory rate which should be less than 30, the tidal volume which is in the range of 4 to 6 ml per kg, and F by Vt ratio, or the frequency by tidal volume ratio, somewhere between 60 to 105. So these are the classical weaning indices which anyone would take into account when we discuss or think of weaning the patient. So as I said, NIF stands for negative inspiratory force, and it measures the patient's maximum inspiratory effort after exhalation. It is measured when the breathing circuit is closed following a manual extended expiration by the patient. And so the value of less than minus 30 centimeters of water, the weaning can be successful. And it is relevant because it indicates a probability that the patient can be weaned successfully. So NIF stands for negative inspiratory force. Now the step 2 is how to manage the sedation. It is very clear by this point in time that there are negative consequences of prolonged and deep sedation in the form of reduced 6-month survival, increased hospital mortality, longer duration of mechanical ventilation, and longer ICU stay. So it's definitely a big hurdle in the process of weaning. And the goals of sedation is to keep the patient calm, comfortable, cooperative. It reduces the anxiety and agitation. It facilitates the mechanical ventilation. Of course, it will decrease the traumatic memory of the ICU stay and the procedures. So these are the various strategies to prevent the need for mechanical ventilation. So in the first place, can we have an option that the patient does not get ventilated at all? So there are a few strategies, as we know that the evidence-based approaches to reduce the need for mechanical ventilation, the early goal-directed therapy for sepsis, use of non-invasive ventilation, especially for the patients of exacerbation of COPDs and pulmonary edemas, use of smaller tidal volumes, especially the ARDS net, as we know, daily interruption of the sedation, early physical and occupational therapy with minimum use of sedatives, even if the patient is on ventilator. So as you could see that the patient is walking with the ventilator on. Conservative fluid strategy, and of course strategies to reduce VAP. So these are the important, very important preventive strategies. As we say, prevention is always better than cure. Now as far as overcoming the endotracheal tube resistance is concerned, because it will increase the work of breathing, and they studied the three strategies of TPs, the pressure support and CPAP. There was no difference. And of course, in another paper in AJRCCM published way back in 1998, where they actually compared TPs versus extubation, again the work of breathing was not very statistically significant. With a failed TPs trial, less than 30 minutes, when we call it as a failed, when it is less than 30 minutes, the patient is required to get reventilated. And the pressure support of 7 for 30 minutes, the weaning success was seen in about 68% of patients in one of the papers in the intensive care medicine. So these are few of the risk factors for unsuccessful discontinuation of mechanical ventilation. So this will signal towards a difficult wean. So when there is failure of 2 or more consecutive SBTs, presence of chronic heart failure, the partial pressure of carbon dioxide which is more than 45 and that we discussed, there was more than one coexisting condition other than heart failure, when the patient has a weak cough, the upper airway stridor at extubation, age more than 65, Apache score of more than 12 on the day of extubation, patient in medical, pediatric or multispecialty ICU, and pneumonia as a cause of respiratory failure. So these are few of the risk factors, and this should signal yourselves to unsuccessful discontinuation of mechanical ventilation. So as I said, the weaning failure clearly has when the patient is anxious or delirious, we are looking at weaning failures. And of course we need to have the metabolic disturbances in our mind, in the form of whether there is hypokalemia or hypo or hyponatremia, hypophosphatemia, azotemia, LV dysfunction, respiratory failure, the muscle weakness. All of these will cause the weaning failure. So definitely that if the SBT which fails, you need to go to a supportive mode and then reassess all the readiness of the weaning the next day. So if one day the trial fails, that doesn't mean that the patient may not get ventilated. Now this is a very clinical and a practical issue which actually I see in my day-to-day practice, that my trainees or junior intensivists who kind of come across a patient who is taking a little long for weaning, 1 or 2 days of failure of weaning, they usually start thinking whether this patient is not able to get weaned off. But here we need to be patient, we need to be vigilant, and of course we need to be aware of the various strategies and the evidences or a few of the guidelines which may help us to wean a particular patient. It is definite that we need to have a weaning protocol in our ICU. It should be evidence based, and we should have weaning trials. And there are multiple studies which has shown that in an ICU which has weaning protocols will have a better weaning successes as compared to ICU which does not have weaning protocols. As far as weaning failure or success is concerned, the weaning success is defined as extubation and absence of ventilatory support for 48 hours following extubation. And weaning failure is failed SBT or reintubation and or resumption of ventilator support following successful extubation, or death within 48 hours following extubation. So these are the definitions. So weaning success we discussed, what is weaning failure we discussed, and weaning in progress is when the patient is extubated but the patient still needs NIV support. So we should, as an exam trainee, you are supposed to know what is weaning success, what is weaning failure, and what is weaning in progress. So these are few of the signs of weaning failure, if you could identify. So I have just put the boxes here. So definitely in this particular box I would say that there is sweating and there is nasal flaring. If there is cyanosis, tachypnea, abdominal paradox, there is definite use of accessory muscles in the form of Allen-Azzi or sternocleidomastoid, and suprasternal and supraclavicular recession, the intercostal recession, and of course tachycardia. So these are definite signs of weaning failure. Now, as far as classification of weaning is concerned, which is based on the international consensus, the European Respiratory Journal 2007 states that the simple weaning, which is seen in about 70% of patients, the patients who proceed from initiation of weaning to successful extubation on the first attempt without difficulty. Difficult wean, which is seen in about 10 to 15% of the patients who fail initial weaning and require up to 3 SBTs or as long as 7 days from the first SBT to achieve successful weaning, and the prolonged weaning, which is again seen in about 10 to 15% of the patients, where the patients who fail at least 3 weaning attempts or require more than 7 days of weaning after the first SBT. So again, this is for the trainee exam going students, be it IDCCM or DrNBs or DM. they will be asked the same. And just I think I'll stop here, and in the next video or the last video we will discuss about the difficult wean. And I hope that whatever we discuss will be definitely useful for you if you are exam going or as a clinician. That's all for now. Tata, bye bye.